Happy June 2026, Montgomery County Fire and Rescue. This is our monthly Fire Chiefs video. Today I have in the studio with us Assistant Chief Kaufman, our EMS Chief. We're going to spend the majority of our time today talking about emergency medical services. Before we get into that part of the discussion, I want to first and foremost thank Division Chief Cooper for the many years of service in the organization as a volunteer first, and then 35 years in the system. So we appreciate all the work that you've done, Chief Cooper. We wish you well in your next chapter of life, and I'm sure there's going to be a lot of things to demonstrate all the things that you've done that we appreciate. So when you see Chief Cooper out there, just give him a kudos and thank him for all the great work he's done in the organization. So we are, on July 12th, we'll have an interim Chief of Operation, and that's Assistant Chief Alan Bush. Many of you have already been exposed to Chief Bush. He was the fleet manager for, the fleet chief for quite some time, and then he's also helping out with a lot of the technology pieces and other special projects, and I'll talk about one of those toward the end of the video. I want to go next into some recruitment things. We just had a sign to serve a couple of weeks ago for Recruit Class 59. Recruit Class 59 will start on June 15th. That's also the opening for Recruit Class 61 job announcement. So please, we're all recruiters. Please get the word out so we can continue to do the great recruiting that we've seen. Recruit Class 58 will graduate on the 26th. So many things are happening that's extraordinary in our recruitment space. We also will have our second Girls Wired for Fire cohort coming up in July. We have already received $20,000, $5,000. We won a grant from the International Association of Fire Chiefs, and Dark Horse donated $15,000 to support that event. That's the second grant that we won from the International Association of Fire Chiefs, and that's the second time that Dark Horse has supported this event. So a lot of great things there. Looking forward to the next cohort. Also, our inaugural Community Fire Academy has already started. We've been in operation with that for several weeks now. We have about 20 personnel, a little bit more than 20 of our community members taking part in that. The goal is to expose them to their department so they understand our mission, how we execute our mission, our needs, and they can advocate with us to continue to get the resources we need to accomplish our mission. Real quick, we did receive the Office of Inspector General audit several months ago. It focused on emergency medical services transport fees. So we have convened a joint committee with our Montgomery County Volunteer Fire Rescue Association members, as well as Division Chief Del Pozo's group, to go through updating a policy and improve the procedures so that we can be most efficient with those resources. We are definitely in the space for the October 3rd Leadership Conference, our inaugural Leadership Conference. Battalion Chief Chowinski is kind of leading that. There's so many others that are supporting that event. Please get the word out for us. This is going to be something that we're going to build from the Montgomery County's brand and do some great things to not only improve ourselves but help others around us. So stay tuned for more about the Leadership Conference. With that, I think that starts us off pretty well. I'm just making sure I haven't forgotten anything. Yes, one more thing. So I talked a few videos ago about the International Fellows Program through the International Association of Fire Chiefs. And that's where they bring firefighters from other countries here to help us learn from them and they learn from us. So I can tell you the first week of June, the memorandum of agreement went to the International Association of Fire Chiefs for them to sign. Once they sign that, we'll sign it, and we should see more information that comes out of when about 9 personnel will come to integrate into the department. We're going to use them again to help us prove why 4-person staffing is the most efficient way to deploy our resources throughout the system. So we anticipate that sometime either in July or August to take place, but more detailed information will come from that. And why I'm on the International Association of Fire Chiefs, I've gotten several inquiries about when people are running for different positions in the IFC, does that mean they're leaving their position? No, that doesn't mean they're leaving their position. It's really another ancillary function of their job, an extension of their job, to not only use their expertise throughout, whether it's what Chief Kaufman is going after right now, the director at large for the EMS section, or other different committees or sections that are offered in the International Association of Fire Chiefs. So when someone talks about they're running for something, they're not leaving their current position, they're really just providing their expertise in other areas so that they can share what's going on in Montgomery County, and they can bring back from other agencies some best practices so we can implement them here. So with that, I'd like to turn it over to Chief Kaufman to talk about a bunch of the progress that's happening in your area.
Well, thanks for letting me tap you on the shoulder and invite myself to your fire chiefs meeting. People stop me and say, what's going on? I mean, there's so much stuff going on, and I have a whole list of things here. Please interrupt me as we go and just ask questions or clarify. I'll try to move quick because it's a lot. On the IFC thing, the other thing to point out there, I am running for the EMS section. It's a volunteer position. It's on top of what we do here, and it's about really giving us an opportunity to share what we do and take from other organizations around the country and bring things back here. It's a networking opportunity, and it really bolsters us as an organization. And again, there's no money involved, right? This is just
no, it's more responsibility.
Exactly right. All right, so we are on the tail end of EMS week, which was, a lot of times just comes and goes. I felt like this year was bigger, and we had more stuff happen. And you and I went to Phoenix and were awarded the Heart Safe Award, Heart Safe Community Award for our work with cardiac arrest resuscitation. EMIHS came here and visited and awarded us EMS Organization of the Year for Montgomery County for our work with the ventilator program. And
for the entire state of Maryland? For
this state. That's a statewide. So we had a national award, and then EMIHS gave us the State of Maryland Award. And then Chief Dugan got Provider of the Year for the state. So that was really neat to have Dr. Delbridge and the rest of the staff from EMIHS come and honor us in that way. And then we had EMS awards here last week. Earlier this week, right? So over 3 days, that's one of the greatest things we do is to recognize people doing good work here, and had some county officials come, but really this is about connecting the survivors with the crews and recognizing the crews with just a sample of some of the good calls that we're running. But that was an opportunity for us to reflect on our cardiac arrest processes and on our successes through calendar year 25. So we participate in a national database called the CARES database, and it captures everything. Anytime we attempt a resuscitation in cardiac arrest, we get all the outcome data, and it shows whether the person was witnessed, shockable, and then or not witnessed, not shockable, and then all the downstream impacts for our care. And also what happened with bystanders, telephone CPR, and what happens at the hospital. So in 2025, we had 816 cardiac arrests, total cardiac arrests that we attempted a resuscitation, and we had 49 people that walked out of the hospital neurologically intact. So that is a testament to the work that we're doing here and our community, right? Because most, if not all of those survivors were witnessed by us or witnessed by a bystander who did CPR right away. There's a big gap of people, though, that we are not saving, and some of them are unwitnessed arrests, and there wasn't CPR done for a long period of time. And even if we get return of spontaneous circulation, they don't end up with any meaningful neurologic outcome. And the biggest way to close the gap is to improve our bystander CPR. So if we can get our telecommunicators to identify the arrest earlier, give CPR instructions earlier, and really envision a community where everybody knows how to recognize cardiac arrest and do hands-only CPR, I think we can close that gap. And just a shout out to Lieutenant Irv Smith for his Take 10 Montgomery program. That's really important.
Yeah, we have an event coming up on the 6th
Yeah.
Of June at Blair High School, where we partner with which hospital? Is it MedStar?
Yeah.
Go out and do that. Where we're at the school. Some other nonprofits will be there. We get to partake in engaging in the community, talk about hands-only CPR, Narcan, Stop the Bleed. So it's really taking it on its own identity, and it's moving across the organization and the county as a whole very well.
The other piece that we're doing behind the scenes, which people wouldn't know, there are AEDs everywhere, but the 911 call taker doesn't know where the AEDs are right now. That is not integrated into our CAD or our dispatch software. So we're working on taking the database of all the AEDs and tying it into our call taking software, so that when somebody calls in with an arrest, the call taker can say there is an AED, on the first floor of your building on the wall next to the men's room. Go get it. Rather than if there's an AED available, go get it. There's a big difference between those two things, right?
Yeah.
Just today, hot off the press, we were once again awarded the American Heart Association Mission Lifeline Gold Award. And this is recognizing our work in collaboration with the hospitals who provide STEMI care for heart attacks and for stroke patients, early recognition, early notification, and rapid transport for these patients, because that's what is contributing to their good outcomes. So this is an award given for multiple years in a row, getting the same thing, because you start out silver, and we've been at gold for I think 3 years now. Wow. So shout out to Captain Wagner for handling the application process and making sure we're staying on top of the metrics. And this is going to come up a couple times, but documentation here is huge, right? So many of these things that we do, and the way we're able to move the system is reliable documentation by the people in the field, and it's a pain. I know, we have a million fields to fill out, but quality documentation and making sure we're writing down everything that we're doing, and from transmitting an EKG to making sure you got the nurse's name at on the signature line, all that stuff is super important for what we're doing with that individual patient. But then in aggregate, that's how we make system changes and recognize what we're doing, right? I'll take a minute to talk about our whole blood program. So we started in August of 2024. So we're less than 2 years in. We estimated 40 patients a year based on trauma patients who had a low blood pressure. And we've actually more than doubled that, and the medical patients, right? So we've had just about as many medical patients treated with whole blood as we had trauma patients. So 171 units of blood given to 136 patients in less than 2 years. We're by far the largest program administering blood in the state, and really, really good outcomes here with bridging the gap from scene to the hospital, whether it's the operating room or advanced medical resuscitation at the ER. So, and again, this is a testament to the work in the field by the people who are calling for an EMS supervisor on the medical calls when they weren't necessarily due. We're running the traumas on the jump, but we're not getting out the door on the medical calls. So we rely on the people in the field to call for a duty officer to give blood for these patients.
Talk to me about the work you've been doing on Capitol Hill.
Okay.
About the legislation.
Sure. So I think bigger picture, we need to think about how EMS is reimbursed for the work that we do. Okay. And back in the day, it was we went out, we picked somebody up, we took them to the hospital, and that was the scope of work, if that was it. We've clearly moved into areas where we're doing advanced treatment on the scene. We stabilize patients before we move. And if you think of something like a termination of resuscitation, where actually more than half of our arrests end up as a TOR, there's no reimbursement for those calls because we didn't move the patient, right? So it's an outdated model the way EMS and reimbursed, and this is reimbursed, and this is a federal thing, right? So the only way to change that is to update federal legislation. But specific to our efforts to recoup the costs on the blood administration, that's the Rescue Blood Act. I guess I'm kind of the show pony going around with lobbyists.
You're the subject matter expert.
Going around with lobbyists, talking with legislators to gain support for nothing more than asking us for at-cost reimbursement for the blood case. So it costs us about $1,700 a unit of blood to administer. That's on top of all our other costs associated with running a call. So we'd be looking forward to recoup those costs just so we're not losing money and we're able to continue to provide this program. So it's very expensive, but it's absolutely one of the most life-saving things we've done in many years.
So as we talked earlier about International Association of Fire Chiefs, because that's who we're going to Capitol Hill with, we're fortunate enough to be able to implement that whole blood program without this intact, without this legislation intact. But think about so many jurisdictions that don't have that luxury, and the work you're doing is helping able to reshape that so that others could also have that ability to have a pre-hospital whole blood program.
That's right. So there are a lot of programs that speak to the startup of the whole blood program, and there's some grant programs, actually, Safe Streets for All, and some other things that are out there now that make it possible for smaller organizations to get the funding to start up. But there's nothing that is
maintains it.
There's no sustainable
Yeah.
there. So that's what this program would do. Just a real quick note that our protocol updates are due by July 1st. So I looked just before we met here, and there's over 1,000 people in the organization who haven't done protocol updates yet. So you have time, but you don't want to wait on that because that is a drop-dead date of July 1st. If you haven't done it, you can't work. So make sure you get that done. I've been getting some questions about Ebola. So there's an outbreak in DRC, in Uganda, in Africa. Very low risk here in the U.S., but people who've traveled to that area have to, by federal rule, have to travel back through Dulles. So there's a potential that somebody exposed maybe in our area. This came about in 2014, so we've kind of dusted off some of our supplies and our processes for screening at the 911 center. Again, very low risk, but just to answer the questions, I did update the novel hazard brief with some of the CDC information. From our perspective, it's the 3 I's: identify, isolate, and inform. So you're going to identify somebody based on travel history and their symptoms, isolate using standard PPE, and if you're doing procedures that are going to aerosolize secretions, we're going to go into airborne precautions, and then inform. So this will probably be a hazmat call for a wet Ebola patient, call an EMS duty officer so they can make notifications. And then something different since the last time for those who have been around since 2014, Holy Cross used to be a receiving facility for highly suspected diseases, and now they're no longer a receiving facility, so we can go to MedStar in DC or Johns Hopkins as a destination. Again, you will have support and help here, and it's very low likelihood that we're going to come across this, but the information is out there. Talk a minute about our fall ALS paramedic training program, which we do every year. This year I sent out an email to the officers requesting some customized recruitment, so for them to identify people who might be good candidates for the ALS program. And people have asked me, well, are we in danger of not having enough applicants? And this was really not about that. We are looking to increase the number of blue shirt firefighter paramedics, so they really targeting the people who just have a couple years on the job that might be good candidates to get their paramedic status. We train our own, we identify our own, put them through the training academy, which is a very good but very intense and challenging program. We've raised the bar on purpose, right? We were doing a lot more advanced things, and we want people to be very trained and up to speed and competent with what they're doing. So that no worries about my email out to the troops, but it was really just about getting our numbers higher than what they are, and for us to increase the number of blue shirt paramedics we have. And we did. We got a lot of applicants, and they're going through the process right now before the class starts in this fall. So.
Good.
Shady Grove is opening a new tower in less than 2 weeks. So on June 14th, many years in the making, they're moving a whole bunch of critical services, including the emergency room, to a new tower. Anybody who's been working Battalion 3 or transport to Shady Grove has seen that work over the last couple years. finally coming true on June 14th, actually late night. So if you're working on the 13th, you'll have a new emergency room entrance in the middle of the night there. I toured it a couple days ago. It's remarkable. The space is spread out. It's state of the art for both resuscitation rooms, the triage process. It's going to be really great.
Any bed space increase?
I knew you were going to ask
Okay.
that. So it's the same size,
Okay.
and this is all regulated by the state. So when a hospital builds or does construction, they have to get approval by the state to make any bed size allocation changes. There's no difference in the size of the ER, but they do have more physical space to expand in cases of surge, including the old emergency room is not going to be allocated for anything. So if they can get staffing up and running, they would be able to use those older clinical spaces to surge and see more patients.
Got it.
Along the same lines, right on the heels of that, the end of this month, the Germantown Emergency Center is closing. And that happens on the 30th at midnight. They're closing the doors. The staff from the Germantown Emergency Center is going to move to Shady Grove, and they're going to be able to increase the staffing of the new ER with the staffing from the GEC.
Okay.
So we imagine that a lot of the patients walking in and by EMS are going to end up going to Holy Cross Germantown. A little bit on the numbers, and this is off the top of my head, but we take about 40 patients there a week, so 160 a month, 2,000 a year. Given the increased capabilities at Shady Grove and the fact that the patients who go to the GEC are generally not sick, right? They're lower acuity because there are no admission capabilities there. We could direct a significant number of the EMS patients that go to the GEC to Shady Grove so that we're not overwhelming Holy Cross Germantown.
Okay.
They're a fantastic facility, but they're limited on the space. They're a small hospital. They only have 14 beds in their ER, and they surge up to 21. I want to talk a little bit about our demand for service, which has continued to rise and far outpace our increase in population. So we have just finished up a really challenging budget year. It's no secret that I came to you and asked for additional transport units, an additional EMS duty officer to help keep up with the demand, and we were not successful, right?
Okay.
So we have to think about other ways to address the demand, and we're put into this space to innovate and partner with people that are not standard partners for a fire-based EMS system. Before I get into that, I want to touch on the impact of the last transport unit we added at 26. So ambulance 726 Bravo went into service at the end of December. So I ran, I think these are 150 some days before and after that date to show the impact of adding that ambulance. The units at 23 are the busiest in the county in terms of unit hour utilization. So if you're looking at the slide, this MUHU, if you multiply the 0.51, like on ambulance 723 by 100, you get 51%. And that's the amount of time out of the course of the hours that we're looking at that ambulance is physically status on a call. So this is looking at peak time from 10A to 10P. You can see the ambulance from 23 is on a call 51% of the time. By comparison, after the addition of ambulance 726 Bravo, that unit dropped down 2%, down to 49% of the time. So kind of technical, and it doesn't account for number of runs. This is just about the percentage of time they're on a call. So we are seeing some impact from the ambulance at 26, particularly with obviously the other unit that sits at 26, but it is affecting the units at 23 as well. Okay. Not much more to do at 23 other than add a third transport unit there, which we know they're space limited to do it. So I want to acknowledge the amount of calls that they're running and the volume that they're put under, and also the amount of time it takes to run a call there, right? Given their transport time turnaround. So some of that innovation we talked about. So how can we help curb demand? One of the things is to divert the 911 call totally so that we're not running the call. So if somebody were to call 911 and have right out of the gate a low acuity complaint, so somebody's skin is itching or they have toe pain, the standard one we say, rather than dispatching an ambulance, if we were to send that caller to a nurse on the phone and have them navigate the patient to healthcare outside of emergency services in the moment, and with no detriment to the patient and also no impact to the emergency service, then that would be a win across the board. And if you do that at scale, we could potentially reduce our demand by a few thousand calls a year. So we're in the very early stages of socializing a nurse navigation line with the 911 center. That would be based at the EMD code level that Dr. Stone and the nurse navigation company goes through and recommends, all right, this EMD code doesn't get a dispatch, it goes to the nurse nav line. So we're working on that right now.
Okay.
Another thing would be a nurse practitioner that is assigned alongside a paramedic in the field working with us to run calls out in the field and attempt to not transport, to treat that person in place and not transport to the hospital. That would save the transport unit and decompress the emergency room. So we're, again, in the early stages of trying to find a partner that would support an NP working alongside us in the field. But one of the coolest things we've done, I think, in some recent years is really administrative behind the scenes. And I'll highlight the work that Captain Wagner and quality improvement folks have done with Kaiser. So this is specific to the 655 Watkins Mill Road in 8's area. They came to us, and well, we heard it on the radio, you know, just multiple times a day, but they were not quiet about letting us know how frequently they were running this address.
Yep.
And after multiple meetings with their leadership, all the way at the national level, recognized that there were factors at their facility that were lending to them calling 911 more than they should. So we're at the point now, after many years of working with them, that we have a relationship where we can send them calls that we think were not right to have used us. Municipal units are here for the undifferentiated complaint in the community where somebody thinks they're having an emergency. At Kaiser, and this is specific to the advanced urgent care, there's physicians and nurses that have already figured out what's wrong with the person and a lot of times already provide care. So if they're stable and can get to the hospital in another way, if they do need to go to the hospital, we ask them to use a commercial ambulance rather than calling us, and in fact they have. So we've, on the screen you'll see our 2022 calls were 861 a year, and in this year we're on trajectory to run 473. So cutting that down by almost half is certainly helpful, and the calls that we are running, we know the busier they are, the busier we're going to be, but the calls are appropriate generally for 911. So that's important. If we were to run this up scale, take what we've done at Kaiser and start working at the skilled nursing facilities.
Roughly how many do we have?
Not roughly, we have 35. So if you were to, and so we're doing this now at 9909 Medical Center, and we started the same type of meetings we had with Kaiser to work with them and say, you have medical staff here, we really shouldn't be running a routine BLS call at your facility, and breaking this down call by call. First of all, getting them to understand where we're coming from, and then you get into the weeds of looking at call by call and saying, are we really doing the right thing here? Starting to move the needle, very early conversations there. Assuming that's successful, we could scale that up to the 35 SNFs and potentially reduce the calls that we're running at the nursing homes. If you add up our nursing homes plus our assisted living facilities, that includes like group homes and everything like that around the county. There's like 275, 280 assisted living facilities. If you add up all those calls, it's like over 13% of our runs are happening at those facilities. So if we're able to develop those relationships, very labor intensive, by the way, but if we can get that up and running and reduce our demand on that end, I think this is a win, but very outside the box and not something that...
So you're telling me, because you just mentioned Ambulance 726 Bravo, that was 10 firefighter positions and a transport unit, which was a several $1 million budget request,
Sure.
right? That was very challenging to get that approval with everything else that we were asking for in this current budget cycle, right? And you said that was a 0.2% difference. Did I hear that right?
0.2%. That was a 23 ambulance.
So what will be the ask?
Yeah.
What will be the ask
yes,
for?
Yes, we are moving the needle, and this is not to discount the fact that we do need
transport
units.
Yes.
Right.
But what would be the ask?
But the ask initially would be, if you can, am I asking you right now? For
Yes.
You can. I would like a full-time equivalent. I would like a uniformed officer to work for Captain Wagner and develop these relationships with the SNFs and go in and speak with their staff alongside Dr. Stone and their medical director to have direct clinical conversations about the appropriate use of 911 versus commercial ambulances.
And you believe, to scale, that would that return on investment will get us what?
Well, if you scale this up across all the SNFs, I mean, we're looking at a reduction of 4,000 or 5,000 calls a year, which is 2 transport units worth of work. So,
Got it. Okay.
Yep.
I hear you loud and clear.
Thank you. Is that a yes?
That's a hear you. I hear you loud and clear. I have more work to do. I've already started those discussions, but I have more work to do to try to get us there.
Good. And then there's some changes coming for the way we do business at the dispatch center. I'm not speaking about the staffing program there. This is about the dispatch of resources on the EMS runs. One of the things we've talked about is reducing our lights and siren responses for safety reasons and increase the number of routine responses. So if you look at our number of hot responses versus cold, we're at 73% hot and 27% cold. And if you were to think about this in the cleanest possible way, where we have all of the information that we could possibly have, and we don't have all the information from the 911 center. We do the best we can and guess about what's happening. But we do life-saving interventions about 6% of the time, meaning we do an airway maneuver, we give epinephrine, we defibrillate. These things happen a relatively small percentage of the time. All the other times, there's not necessarily, there's things that are important that we get there, but there's nothing life-saving about the actions that are happening on the call. So in an ideal, perfect world, we would respond with the lights and sirens identically matching that 6% of the time. We need to get closer down to that number from where we are now at 73, and the only way to do that is to start looking at responding routine to ALS calls, which, you know, when I start bringing this up to people, they're like, what are you talking about? The people who are doing this right are Wake County in North Carolina. They're at 20% hot and 80% cold. So I wanted to inform you and the department about the processes that Dr. Stone uses to make the decisions about a safe ALS-1 routine response. This is a very busy slide, and it looks at 2 years worth of patient care records, and there's several different things that we look at all the way down to the EMD level. This one's sorted by the most frequent number of incidents that we run. So the most frequent call we're running is a 26 alpha 10 or a sick person routine response. Across that determinant, we look at the number of reports that we wrote, the number of times we did a life-saving intervention and the percentage of time, the number of times there was a transport urgent patient out of there. So even a smaller subset of potentially life-saving interventions did the person need to get to the hospital quickly? Were they having so it's something we can't fix in the field, STEMI, stroke, surgical trauma patients. Those are the times we need a transport unit there quickly. We move them to the hospital. Further to the right, and it's not showing on the screen here, cardiac arrest cases, the number of medical procedures that we're doing, the number of medications we give, the times that ALS goes to the hospital. So we look at this at each EMD level and determine when might it be safe for ALS to go routine. And those are times where we did no life-saving procedures. It was not transport urgent. There were no cardiac arrests. And it's not to say I didn't need a paramedic there. I did need a paramedic there, but I didn't need them there urgently. So we've taken a very conservative approach at dipping our toe into the ALS ones. And the call types include some allergic reactions, some back pain that end up ALS1, and a couple others that get us to about 3,500 responses a year that will cut from hot down to cold. Yep. Okay. So that's coming, and I wanted the department to know that we're not guessing, right? We're using, this is 2 years of outcome data based on, you know, large volumes of calls for us to make decisions, right? And that's based on your general order from the end of last year, 2509, that gives us the authority to run things routine. And a couple things, just more reminders to close things out. Our direct-to-triage program, and this is really helpful when we're really busy in the system and the hospitals are busy. Recognize that the patient can go sit in triage, so they're stable. They can sit up in a chair, run it by the charge nurse over the radio, and touch base with the charge nurse when you get there. If you're running into situations that the charge nurse doesn't agree or is telling you, well, you got to wait in line anyway, get on the phone to the EMS supervisor, because that's not how this program is designed. We want to shorten your time from arrival until you can get back in service, because we do not want you waiting at the hospital, right? We want you back serving the community. And a reminder about our alternative destinations. So we still have this program where we can transport patients to Kaiser and 5 of the MedStar urgent health cares, or urgent cares around the county. It includes the Casey House, although that's, the criteria there are, have to have a patient who's enrolled in hospice and is a DNRB before we can transport to Casey House. So their criteria are not the same as the other ADs. And the Crisis Center Stabilization Room, which I'll point out right now is closed for renovation. They're increasing the number of recliners from 4 to 8. They're building a separate entrance for EMS with a ramp, and they're scheduled to reopen in November. So a reminder that these programs are still there. EMS 700 should remind you, when you have a really low acuity patient of the process there. And yeah, I hope I got through everything and didn't move too quickly.
Well, it's not. It doesn't go without saying that there's a lot going on in Montgomery County Fire and Rescue Service.
Sure.
78% of what we do is in your shop, right? Or is it more?
I think it's more. It depends on how you add it up. But yeah,
78+%
for sure.
of what we do is in your shop, and with all the awards you talked about earlier, with all the things you just discussed about what's happening and what's coming down the line, we are doing some great things, and the first responders out there, the firefighters, EMTs, paramedics are all doing some great work, and thank you for your leadership in that area. I got one more question before we move on. If you had to talk about technology and AI use, what were some of the things that you can talk about that we're right on the edge of implementing?
So ImageTrend software has what they call AI Assist that's built into within the software. It's not true AI. It's running alongside the software contained. So it's not out as a learning model, but it is. It's designed to help you write your reports faster. So, and it's kind of backwards from the auto-generate narrative, where you'd fill out all the drop downs, and then it would pull from the drop downs and write your narrative for you. This works the other way, where you write your narrative, and then it auto-fills your drop downs. So it's intended to pick out things from your narrative and help make you more efficient in writing your reports. So that's one thing. There's models where you can go voice to text, and then it will clean up so you can just speak and say, hey, I'm on the scene of whatever, and speak normally the way you and I are, and it will pick out what you're saying and clean up that to make it a medically defensible narrative, and also fill out your drop downs at the same time. Both things are coming. I think AI Assist will be the first thing that we're able to turn on. It exists in ImageTrend right now, and we're testing it and running it through county security things to make sure that we're good to go. The other programs are probably going to run outside of ImageTrend, but will be very helpful. The other thing that's cool is a CQI module that runs in real time as you're writing your report, to make recommendations to help you make sure you're answering all the questions correctly and avoid the questions that come in afterwards, either from billing or from the QA office. So it's pretty neat. The stuff that runs alongside in real time is I think, the future, and is really going to make the difference here. So, yeah. All
right. Well, yeah. Chief Kaufman, I appreciate your time. Montgomery County Fire Rescue, we're going to close out to talk about the National Fire Incident Reporting System. It's gone. It no longer exists. And there's a new standard, which is the National Emergency Response Information System, now called EMIHS. The department has to migrate to that platform to stay compliant in order to be aligned with the state and national requirements. We need to continue to collect good data in order to make good decisions about deployment and operations. You are an important part of this process. The department has chosen to use EMIHS Trend as our reporting platform. This has been a lightning speed project starting in February of this year and launching now. What are the advantages? We are already within the contract with EMIHS Trend. Most of our operational personnel are familiar with EMIHS, and the look and feel are very similar. MCFLS has already had the in-house expertise to be able to customize the run forms to make it easier for our responders. Depending on the call type, required fields are highlighted for the end user's convenience. We have created preset incident buttons that will pre-populate multiple fields for the end user. The narrative portion will accept speech to text if users wish to use that feature. Similar to EMIHS, the program is web-based and does not have to be accessed from within the county IT network. We expect that the vendor will roll out AI assistance for real-time coaching. This may even occur before our go-live date. A couple of caveats. Bottom line, please be flexible and expect that there will be updates and changes. EMIHS is in its early days, and national changes for reporting and rules are still rolling out. We will continue to develop validation and visibility rules to make it easier for the end user. Your feedback is paramount. We need you to do the training. Practice data entry before we go live on July 1st, 2026. Provide feedback via the job form listed in the training announcement. We need your help to make this system better. A few people deserve credit. Dr. Schultz for serving as our in-house EMIHS expert and figuring out which data fields are important for collection. Battalion Chief Scott for doing the heavy lifting of form configuration. Mr. Firetag for developing the training. Ms. Song for managing the data handling processes and ensuring that our data gets properly stored in our data warehouse for use by our analysts. Mr. Baldwin for handling the physical infrastructure needs. Assistant Chief Baltrowski for handling the CAD feed integration. And last but not least, Division Chief Bailey for supporting the project with priorities and fiscal resources. Montgomery County Fire and Rescue Service, this concludes our June 2026 video. As always, thank you for what you do. Take care of one another and have fun.